Hello, my name's Martin Chapman, and today I want to talk about a piece of work conducted between King's College London and Imperial, exploring how computable phenotypes can be used to determine eligibility when recruiting patients for clinical trials. I want to start with two high-level definitions. The first is of computable phenotypes themselves. Computable phenotypes are based on what we call EHR-based phenotype definitions, which are high-level pieces of logic that describe how to extract cohorts of patients from a given population, such as the population found within a set of health records. These high-level definitions are used to realize computational implemented forms, which we call computable phenotypes, and these can actually be executed in practice against something like a health record. Here's a brief example for type 2 diabetes. Our high-level EHR-based phenotype definition is expressed here as a flowchart, and this can be implemented then in multiple ways. Here we can see one has a pipeline implementation, and we can see another implementation that is in SQL. Our second definition is for clinical trial eligibility criteria. These criteria express the characteristics or properties that a patient should have in order to be considered for, or indeed excluded from, participating in a trial. In a special type of clinical trial recruitment, which we call point-of-care clinical trial recruitment, eligibility is not determined offline, but in a live manner, typically when a patient presents during something like an appointment with a general practitioner. As is probably clear, there's some overlap between both computable phenotypes and eligibility criteria. They have similar goals, which is to determine certain cohorts of patients that are of interest. At the same time, we see increasing work taking place to develop large repositories of EHR-based phenotype definitions. This leads to the natural question, which is, given the popularity and rise of EHR-based phenotype definitions, can we use them in a computable form to determine trial eligibility? And one of the ways to determine this is to look to determine whether computable phenotypes exhibit the certain properties that are required for use as eligibility criteria. We've identified three for the purpose of this study. The first is that computable phenotypes should be suitably portable. It should be possible to define them and use them for a given clinical trial, and then allow that definition to be used again for future trials so that effort is not wasted. Computable phenotypes should be compatible with existing trial infrastructure. They should be able to plug in and be used to determine eligibility in existing systems. And finally, and of course most importantly, they should be accurate. So they should accurately identify patients that are eligible for a trial. To explore whether computable phenotypes meet these properties as a part of this study, we focused on a particular clinical trial, that's the REST trial, which was designed to compare different treatments for AOMD, acute otitis media with discharge, in children. And we first looked at how eligibility criteria were expressed in this trial. And these criteria are expressed using something that we call open EHR-based archetypes, a subset of them at least. An example here is shown for the eligibility criteria that we used for date of birth, which uses this standard, as well as something that we call CDIM, which allows for compatibility with multiple data sources. Our first task, therefore, was to define equivalent functionality for AOMD using a computable phenotype. In particular, we chose the PhenoFlow standard to do this, which contributes a particular model for the representation of phenotypes that's based on the idea of workflows with multiple steps. So we took the functionality of these existing OpenEHR-based archetypes, and we represented them under the PhenoFlow model. An example is shown here for AOMD, and this particular step of functionality is identifying patients with certain clinical codes that indicate that they do indeed have AOMD. And there's a separation here between the abstract logic and the implementation, which suggests a degree of portability. Our second thing to do was to determine how these eligibility criteria were actually implemented or used in practice for point-of-care trial recruitment. For REST, a particular piece of software was used, which is called Transform. And what Transform does is essentially connects in with a patient's record when it's opened during a particular consultation. And when that record is open, it takes the eligibility criteria, which are expressed as archetypes, and translates them into a concrete implementation, something like an XPath query. And using knowledge of the structure of the EHR source, we'll explore that record to determine if that patient is eligible. To enable our phenotype-based eligibility criteria for AOMD to be used within the system, we developed a new service, the Phenotype Execution Microservice, or PHEM. And this will then allow our computable phenotype to instead plug in, and rather than archetypes being used as we saw previously, the phenotype definition will be used instead to determine eligibility when a patient presents. The next step was to compare how our new computable phenotype representation for AOMD compares to the original archetype-based criteria. And to do this, what we did was to re-simulate the REST trial. We started off by generating a synthetic population of patients. This was informed by the REST trial itself, which allowed us to get an accurate population size. This was about 10,000 patients. And the second was to actually use realistic types of AOMD that would be present in the population. And we fed this all into the Cynthia population generator, which allowed us to get real-world distributions for these conditions. We then set transform up in a simulation mode. We had it investigate each of the patients in this population and determine if they were eligible or not, first using the archetype-based criteria and then using the computable phenotype-based criteria. What we actually saw is that the use of phenotypes actually offers a similar level of recruitment in terms of accuracy to the archetype-based eligibility criteria, and in fact in certain situations actually offers improved accuracy. One of those is when recruiting by age. As we can see here from the graph on the left, the archetypes actually miss patients at the lower end of the required age spectrum and actually erroneously recruit patients at the higher end of the age spectrum. So here we can see the archetypes of missed patients of age 1 and have incorrectly recruited patients of age 16, which falls outside the trial parameters. This is because the use of archetypes requires a static date of birth declaration to determine age, which actually becomes less valid as the trial proceeds. Instead, when we use phenotypes, we have more of a dynamic understanding of age, which is why it correctly recruits patients at the lower end of the spectrum and doesn't recruit patients outside the top limit at the end of the spectrum. At the same time, in a similar way, we can see that from the graph on the right, that archetypes actually miss key codes that might develop or be added during the progression of a trial. In REST, for example, a new COVID-19 based AOMD type code Y20FF was added during the trial. But because using archetypes we're required to statically define codes at the beginning of a trial, this was missed during recruitment. Instead, using phenotypes which have access to dynamic code lists, we're able to recruit more accurately here, so we can see that the phenotype has accurately captured patients with that condition. So let's return to our initial requirements for using computable phenotypes as eligibility criteria. We said that they needed to be portable so that these criteria could be used for future trials. And we can see that the use of PhenoFlow prioritizes portability by design. So by using phenotypes, we get this inherent level of portability. Our second criteria was that phenotypes should be compatible with existing trial infrastructure. And we've seen how the use of this new microservice allows phenotypes to be plugged into the transform infrastructure to enable eligibility checking. This, of course, now sets a model or a blueprint or provides software which allows for different phenotypes to be used in future trials. Finally, and of course most importantly, the use of phenotype should accurately recruit people. And we've actually seen that the use of phenotype not only provides the same level of accuracy when recruiting as archetype-based mechanisms, but it's actually more accurate in certain situations. There are some things to think about in terms of these results. The first is the fact that when we use phenotypes, there is an execution time cost. This is because obviously executing these slightly more complicated entities does take longer, and this is something that we found as a part of our simulations. The second is to note that the use of archetypes is not entirely static. They can be updated during a trial to address some of the issues that we've seen, but this does require expert human intervention. And of course, the utility of adding things like PHEM to transform is predicated on having high-quality phenotype definitions continue to be developed by the community. Thank you very much.